Critically ill patients are complicated. Organized and systematic presentations of patients are crucial for good communication, safety, and efficient care for complex patients. Learners in the ICU must understand how to be both thorough and efficient when presenting their patients. This comes through taking ownership of the patient's hospital course and engagement with the patient's care plans. ICU patient presentations, whether on rounds, during sign-out, or when transferring a patient to another medical service, are usually organized using an organ system-based format. Using a note template can assist learners in both gathering and presenting relevant information. This is one example of a note template that learners can use to gather patient information and to organize data for presentation. Note a few important items. Date of hospital admission and date of ICU admission may not be the same and can tell the audience an important part of the patient's story. Similarly, knowing the patient's past medical history sets a backdrop to the current problems the patient is experiencing. The events over the last 24 hours gives the team important understanding on how the patient is progressing. Is the patient getting better or worse? Were previous plans for the patient accomplished? Are there any new events or complications of concern? Current medications must be reported, paying special attention to prophylaxis for DVT and PE and stress ulcers, as well as good antibiotic stewardship. If the patient requires vasoactive drips, knowing whether the doses are increasing or decreasing is also key to understand for the patient's progress and recovery. Reporting mechanical ventilation settings also helps the team understand whether the patient is improving and requiring less support or worsening and requiring more support. Reporting the mode of ventilation, the FiO2, the PEEP, peak inspiratory pressures, and the patient's work of breathing on physical exam are all important pieces of information. If the patient underwent a spontaneous breathing trial, then knowing the results of the Rapid Shallow Breathing Index is important for determining success of liberation from the mechanical ventilator. Fluid status, or balance on intake versus output, should be reported daily as it is valuable information for understanding good perfusion, urine output, and hemodynamic status. Noting any invasive lines, tubes, or drains and whether they are still necessary is important for preventing iatrogenic infections. When reporting on the patient's past and present medical history, we want to hear a chronological story of the patient's medical problems and treatment since admission. Here is an example. This is a 36-year-old male with a history of diabetes mellitus, who was admitted to the hospital on December 25th with nausea and vomiting. His diagnostic workup included a full blood count, a metabolic profile, and a CT of his abdomen and pelvis, and he was treated for diabetic ketoacidosis with fluids and an insulin infusion. We were called to evaluate him for admission to the ICU because of altered mental status and an anion gap metabolic acidosis. When reporting on any procedures the patient has undergone, we want to know the exact procedure. Tell us about transfusions, IV fluids, urine output, and blood loss. Tell us about anything else notable, a difficult intubation, hypotension, hypoxemia, vasopressor requirements. What drains were left in place? If the patient had any other procedures, tell us about them, unless you've already mentioned them in the history. Does the patient have a chest tube, an endotracheal intubation, or an abscess drainage? When reporting current problems, list every problem that we are treating and anything we need to keep in mind to treat the patient well. Use diagnoses as much as possible. If the diagnosis is not clearly known, then use symptoms or syndromes. For example, rather than saying leukocytosis, fevers, and tachycardia, say sepsis. When reporting events over the last 24 hours, tell us what was done after admission to the ICU or within the last 24 hours. If it is a new patient, summarize events over the last 24 hours after arrival in the ICU. If it is an existing patient, list what has happened since yesterday and the goals that were outlined. When reporting objective data, report the last 24-hour vital sign ranges. For example, the heart rate ranged from 56 to 93. Also report the ventilation settings and any major changes that have occurred in the last 24 hours. Also report 24-hour medications. List every medication the patient has received, including one-time doses. For IV infusions, you must know the total dose, not just the volume infusion. For antibiotics, list how many days the patient has been on each antibiotic. Also, report 24-hour intake and output. Physical exams should be performed in a targeted way based on the patient's condition and reported back by systems, including neuro, cardiovascular, respiratory, abdomen, upper and lower extremities, and wounds, lines, or tubes. Investigations should report any pertinent investigations in the last 24 hours, or if greater than 24 hours, any relevant recent results. Finally, the assessment and plan must be presented by organ system. Assessments should include differential diagnoses for each problem and include supporting data. Developing broad differential diagnoses listed by most probable is the goal for early learners. As your understanding of critical care increases, your focus will shift to the most likely disease process etiologies and developing sound critical care plans. Senior learners, experienced ICU nurses, and ICU-trained physicians are your mentors and teachers, but you control how much you learn while engaging on rounds and through independent studying.